Doc Talk with Dr. Paul Conley is a production of TTV, which is solely responsible for the content.
Hello, I'm Dr. Paul Conley, the host of Doc Talk, and thanks for tuning in to another episode. Tonight we are here in Oak Hill. We're here in Main Street, and we are here at the Oak Hill Sleep Lab. And so we have Dr. Heather Clawges here tonight, and Dr. Clawges is our sleep expert. And so she is trained in what's called sleep medicine. And so on one of our prior episodes, we were in her Beckley office, and she actually has multiple offices, by the way. So watching the show, you can actually be evaluated in Greenbrier Valley, in the Lewisburg area, Beckley area, which we were at Brookshire. Tonight we're here in Oak Hill, and coming soon, Dr. Claude just told me before the show, this fall in September, there's going to be a sleep medicine clinic that's going to be in Summersville. So in saying that, what I'd like to talk about is kind of dovetail our prior episode, which we talked about sleep apnea, and the show was mainly focused on obstructive sleep apnea. So we're going to kind of talk a little bit about that again. But as important as that, I underwent a sleep study because Dr. Clawges recommended it for me. And so we're going to kind of walk through this equipment that we have in this container. And she actually has my sleep study results, and she's going to go over that with you and me. She's going to kind of go over it with me. And we're going to talk about those findings, but we're also going to talk about just what, if you have findings that aren't exactly telling us what we need to know, how we can get further information from an in-house study, which is what I'm actually going to do tonight. So Dr. Clawges, thanks again for coming on.
Thanks for having me.
So sleep apnea, we talked about that before, all the different things that can be associated with that, high blood pressure, heart disease, stroke, arrhythmias. But, one of the things too, even from our last show, is insulin-dependent diabetes. People that are diabetic, if you have sleep apnea, increases the risk of that, metabolic syndrome. And one of the things too that, we were talking about one of our last episodes with thyroid disorders causing emotional lability, depression, anxiety, but sleep apnea as well. So I guess Absolutely. If you're tired, you're more irritable and
Absolutely.
Cranky. And
weight gain too.
Weight gain. So,
yes. Which
would then again be one of the reasons why, we see the sleep apnea. So yes. Because as you gain weight, then we talked about how that causes issues around the neck. So we talked after the show about how I have had weight gain. Everybody knows I can be irritable, right? And so he's like, well, maybe, and our producer's back there smiling.
Laughing.
He's laughing. So our camera guy's laughing, so they know. So maybe, could I have sleep apnea? And so she recommended a home test. And so what we have here, maybe you can walk through this. This is what you gave me, or actually your associates, and this is, maybe I should go ahead and shut the box and you can open it. So this is what I was given to do at home.
So currently we have two different types of home sleep testing equipment. There's lots of different companies that make different brands, but in general we have two different types. A flow-based, which means that you have a cannula in your nose, a belt around your chest, and a pulse ox on your finger. So that's I wouldn't say older, but it was one of the first types of home sleep testing equipment. Then 5 to 10 years ago, they came up with PAT technology. So what that is it's either a watch worn on your wrist, ring, or finger device that monitors peripheral arterial tone. So what that means is we have changes in our arteries that occur when we're not getting enough oxygen to our tissues. So it actually measures peripheral arterial tone, and that's how it works. And so this test is a newer test that measures peripheral arterial tone. And additionally, which makes this test really exciting, is it has one EEG lead that is in the sticker, which we'll show the sticker here in a second. And so I actually get sleep quality data too. So right now, the only way for us to know what type of sleep you're having is to have EEG leads. That shows brainwave activity, and by your brainwave changes, I can tell what type of sleep you're having. And we know in sleep apnea that's important because it is worse in REM sleep. So when you go into dream sleep or REM sleep, our muscles become paralyzed. That protects us, right? So we don't want to act out our dreams. And so our muscles become paralyzed, but so do our upper respiratory muscles. And so these all relax when we're in REM sleep. And so REM sleep makes sleep apnea worse. And we like to know how much REM sleep somebody's having during the test. So this is a little bit fancier test because it can tell us the amount of REM sleep. So for example, you had 30% the night that you had the study, and that was normal.
And REM is that's that rapid eye movement,
rapid
right?
eye movement, and it's the same type of sleep that we dream in. It's also very important for memory consolidation, concentration, and learning executive function. So we know that when people have sleep apnea, you start having it more in REM sleep. What does your body do? Wakes you up so that you don't have these breathing problems. And then you start having less and less REM sleep. And that's why you can get the memory cognitive impairment when you have obstructive sleep apnea.
Yeah, I know one of the things as you open that up, we talked about all the health issues that we think about, the cardiac issues, arrhythmias, but I know there's been some link between like dementia and memory loss, right, with sleep apnea.
Absolutely.
Because of what you just said.
And that also has to do with a hypoxia. So we know that when your airway closes, you don't get enough air into your lungs, so your oxygen level starts to drop. Those drops in oxygen cause decreased perfusion to the brain, and most particularly to the frontal lobe of the brain takes a big hit. And so that also directs mood, personality, being able to comprehend and understand complex tasks, So we know that people with severe sleep apnea have significant frontal lobe dysfunction.
So I think that, the neurologists, our neurology colleagues, which sleep medicine, you're really tied with that.
Correct.
When you think about anxiety, depression, headaches, but I think most of us, we're really concerned about dementia. No one wants to have dementia. No one wants to be that individual.
Or stroke.
Or again, a massive stroke, which in itself can cause significant cognitive impairment. So, when you talk about how the fact that like, if you're not in REM sleep long enough, how that, of course, over time is going to cause cognitive impairment. Now, you told me I was 30%. Now, 30% to me initially sounds bad. Is that bad, 30%?
Actually, no.
On exam, 30% is like you don't...
15 to 30% is normal.
Oh, good.
Yeah.
Oh, then that's
but
good.
Now the problem can be is some people can have normal amounts of REM but still have significant REM sleep disturbance or problems. But if you have severe enough sleep apnea and REM sleep, usually the body starts down-regulating the amount of REM sleep that you have. So is it a good indicator that you have a good amount of REM sleep? Yes.
So maybe you can show us before the break here. So this is the machine that I put on, or not machine, equipment, or whatever you want to call it, which is pretty interesting how it connects to your phone. And we all have basically smartphones.
Yep.
And even me having an Android, not an iPhone like everybody else, but it works perfectly with that as well. So maybe you can show us exactly what this does.
So basically you download the app on your phone. The app communicates by Bluetooth with the device. And so this is the main part that communicates with your phone. They have a charger because we want to make sure that the device should be charged up when you get it, but just in case, we want you to keep it 2 nights maybe. Some nights I do 1 night regular sleep, and then the next night with an oral appliance, which is a device that can treat sleep apnea, so I can see how well I'm treating a patient's sleep apnea. So there's reasons to do a couple nights. If that's the case, we have a charger, but usually it comes fully charged. We have this sticker. Should we open it?
Yes, I want you to.
Okay.
I want people to see.
I'm not putting it on though. You want to put on the sticker?
You're afraid?
It's sticky.
I'll show you. I did this.
Okay.
Literally.
Ooh, I'm going to drop it.
And you know what? And importantly too is make sure that you plug your phone in, because you don't want to run out of...
Oh yeah, and they can tell. They want you to put your phone on charge for the entire night duration so that it doesn't drain the battery during the...
Yeah, so it has like these 3 prongs here. So this actually connects to this. And then this, like you said, is very sticky.
Snap it on good.
I gotta make sure I snap this thing on good. Like this. and I don't know if you can see this or not, but there's a little green flashy light, and you put it on like this, and there you are. And then there I am, and then I'm on my phone, and it says ready for sleep, and you hit yes, and then it's doing your study.
Yeah.
And then I was doing a little bit of work, because Dr. Clawges said, well, it looks like you didn't sleep for at least 60 minutes. I said, well, I was doing some emails and everything. But then that's where you could actually, I'm thinking, was this really picking up anything? And obviously, tell us what all you found. So 30% REM, so
that's good.
Good.
So it will tell me approximately how long it took you to fall asleep. So that was an hour. So I was a little concerned because under 30 minutes is considered normal. But then you confessed that you were working prior to trying to fall asleep. So
deleting a bunch
that
of
could be
emails.
Normal. So at the time that he decided to go to sleep, we decided it was normal. And then 30% REM sleep. So that's pretty good quality. What we saw is that you had pauses or shallow breathing episodes, so sleep apnea events, 3.5 times an hour. And that's based on a 4% drop in oxygen saturation, which is our insurance guidelines. So below 5 times an hour is considered normal.
So when you say 4%, maybe you can explain to the audience what's a normal oxygen saturation, and then what number would give you some concern.
Yep. So we know that most people should oxygenate in the mid-90s. We should not have any pauses in breathing or shallow breathing episodes that last longer than 10 seconds or that are associated with a 4% greater desaturation. So what that means is the upper airway is closing for more than 10 seconds and the end result is a drop in your oxygen level by at least 4% or greater. Yep. And then we also look at the low oxygen saturation. So your oxygen did go down to 87%. We don't like to really see anything below 90, but definitely nothing below 88%. And you spent 1.3 minutes less than 90%. So a little bit of drops in oxygen, but not anything too crazy.
We don't want too crazy. So,
right.
So one thing you explained to me, you said you could see on this that you could see where this thing would pick up if I head jerked. You talked about me snoring. You could see that. So tell me about the snoring. You said you have primary snoring, and I can see from this blip here that you jerked and you woke yourself up, right?
Right. So that's called an arousal index. So there was an elevation in the arousal index, which means that your brain is trying to keep yourself awake or is waking yourself up to increase that tone in the upper airway. So that was happening about 7.9 times an hour. So that's an indicator that something's disrupting your sleep approximately 7 to 8 times an hour. That's in the mild sleep apnea category. So that's an indicator that, hey, this equipment isn't perfect at picking this up. It's a guideline. It can underestimate sleep apnea, but I'm seeing a little bit of warning signs that there might be something more disrupting your sleep. The other indicator is we can look at 3% desaturations. Now the insurance does not agree with 3%, but the American Academy of Sleep Medicine, so all of us docs say, well, 3% is significant. It can increase your risk for high blood pressure. It can increase your risk for heart disease and stroke. Let's look at that. And yours was 6.2 times an hour. And anything over 5 is considered mild sleep apnea. So although the insurance doesn't recognize this as a problem, we physicians do. And so that is another indicator for us to look at a more thorough test, like the sleep study.
Because one of the things that you had told me after reviewing my study was you had talked about that if I had some other comorbidities, so you use this, so if you had heart disease, if you had other things to go along with it, then that's where we would talk about, and because I said, I really would like to consider having a CPAP mask, and you're like, hold on, not yet, and you said, let's bring you in and let's do the in-house study. So it looks like we're at a commercial break. So what we're going to do is we're going to take a break, and then we are actually going to walk here in the back here at the sleep lab, and we're going to look at one of the rooms, and then we're going to talk about, or Dr. Clawges is going to talk about, what additional information that the in-house study can afford you that this study can't. So Again, we're going to take a commercial break. Stay tuned, and we're going to be right back.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we are delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.
Welcome back to Doc Talk. I'm Dr. Paul Conley, and we are here with Dr. Heather Clawges. And just like I said, at the first half of the show, we talked about my in-house, in-home study. Now we're going to talk about the in-lab study. And so, as Dr. Clawges talked, she got my results. She looked at the reports, and just like she said, I have some primary snoring, some mild degree of sleep apnea, and
You're in a gray zone.
I'm in the zone. She says, now I'm going to drop a bomb on you, and I'm really nervous. I'm on the phone. I'm in between scopes. And I said, what is it? What is it? What is it? She goes, well, I hate to tell you this, but if you lose about 15 pounds, this could all just go away. So again, we do know that people that have some degree of sleep apnea, that exercise, weight loss, obviously, as she's getting ready to leave here and go work out, that in itself is a treatment of sleep apnea and just losing weight so you have less of that neck circumference. Now,
Let me make a comment about that.
Go ahead.
People get frustrated when they try to lose weight and they can't. Sometimes it's hard. We know that untreated sleep apnea makes it much harder to lose weight. So in order to lose weight, you need to identify the sleep apnea and treat the sleep apnea in order to get a handle on the weight. And that's because sleep apnea changes a couple hormones in our body. So it increases ghrelin, that makes you feel hungrier, and it changes leptin. And so that changes the way that your body holds on to fat. So let's say, hey, I know I need to lose 15 pounds, but I'm having a really hard time losing 15 pounds. Then that's when you need to get the sleep apnea or your sleep issues identified and treated so that you can lose weight.
Yeah, it does. And so we do know that there are hormones. We also know that people that have cortisol, there's so many other things. And so people that we just talked about, people have sleep apnea, they have increased stress, irritability. And we know as healthcare professionals, we deal with that all the time. And we also know that increases cortisol levels, and cortisol levels increase, central obesity. But I also tell patients too, if you're tired in your work, because they'll say, well, doctor, I really don't feel like exercising because I don't sleep at all, so I'm tired, and so I just want to go to bed. Yeah. So again, if we get that treated, so again, it actually, one basically perpetuates the other, and so we can get the sleep apnea treated. And so what we want to talk about with my sleep study, which I was in the gray zone, it's not totally normal. It's not the worst you've ever seen, but it's definitely something that we're going to do some work on. So one thing that if you're in that gray zone and you think that you may benefit from treatments of sleep apnea, which we've talked about the dental appliances, and again we talked about that how dentists identify sleep apnea in kids and adults, and also how get referrals from these folks, not just the primary care folks. Myself as an endoscopist, I think I send you a fair amount of patients because I get to witness people sleep during a colonoscopy or an EGD, because during the procedure I get to monitor you, and typically someone's snoring and obstructing during the exam, there's a very good chance that they're doing that also at home. But there's also other things that you can pick up on this in-lab test. So we're in the lab here, and again at Oak Hill, and so we got these wires and everything here, and in a bit we're actually going to get some photos of me with these wires on. So I'm going to actually put all this paraphernalia on, and everyone's going to enjoy that, I'm sure. But so tell me exactly what this study can tell you, because you read these, and by the way, she's really quick at these readings. I mean, unbelievable. I mean, within a matter of no time, she's calling me with my results, because everything now just is like warp speed to her computer. So tell me about what we got here, Dr.
So we're going to start from the head and move down. So we talked about the sticker had one EEG lead. This has 6 EEG leads. So we have 2 at the front, 2 central, and 2 occipital. So it allows me to see sleep quality better. If you think about a full EEG montage for seizures is 19, so not quite 19, but it will allow me to look, especially in kids, sometimes I can see seizure activity that they didn't even know they had, or some abnormal brain waves that they didn't even know the child had. So it allows me to evaluate quality of sleep better. Then the second lead, so now we're going to move down to the eye leads. So 2 of these will go at your eyes, and they're going to monitor what your eyes are doing during sleep. So why is that important? REM sleep has rapid eye movements, and that's how I can precisely identify when you're having REM sleep. So we use the eye leads to look at your eye movements during sleep. Additionally, we have slow rolling eye movements as we enter the first stage of sleep. So I tell parents with new kids, if you want to know when you can move the baby from one place to another, watch the eyeballs. If the eyeballs start moving back and forth, then they have entered stage 1 sleep, but they're not deep enough to pick up yet. So you wait till those eyes stop rolling, and then they've gone into stage 2, and it's usually safer. If you want to wait 30 minutes, it's even more safe. That's the deepest stage of sleep. So eyes give us a lot of indicators about what type of sleep you're having. The next is going to be our, we have 2 ways to monitor flow, which is why the in-lab is way more specific and sensitive to picking up sleep apnea. So one measures a change in temperature. So when you take a breath in, there's less heat. When you breathe out, there's more heat. So it looks at subtle changes in heat that determines your airflow capacity. Then you also have a cannula. The cannula is not on this back of this door that goes into your nose holes, and that monitors the actual flow of air. So one is sensitive at looking at an apnea. An apnea is when you have a 90% decrease in airflow. And in a hypopnea is when you have a 30% decrease in airflow. We know that hypopneas, or shallow breathing episodes, are equally important in high blood pressure, heart disease, stroke, and risk factors. And so this equipment is less better at looking at hypopneas.
When you say apnea, maybe you can explain what exactly is that word. I think when we think about babies, we think about apnea monitors. You know, what exactly is apnea? Sometimes I'll have patients say, yeah, you know, I think he stops breathing, and I shake him. Is that apnea?
Yes.
An apnea
So
episode?
apnea is a 90% decrease in airflow. So a full apnea is 0 airflow, okay? There's 2 types of apnea. Obstructive is when the upper airway closes, and then central is when your brain doesn't tell you to breathe. And so that's where this belt comes in handy, because we have a chest and an abdomen belt, and we look at respiratory effort. So in an obstructive sleep apnea, your chest and abdomen are trying to take a breath, but no air is coming in and out. And then the pulse ox tells me if there's an oxygen effect. Just like I said, insurance wants at least a 4% drop in oxygen here to be considered significant.
So 4% meaning, so that's, which is, I'm glad you brought that up, because, you know, at the break I was kind of thinking, well, we talk about 87%, but if you have a patient who has, let's say, COPD, who already has a low SAT, but you're saying it's, so you could have someone, it's a change, so it's a delta change. So if I'm 98%, and maybe I don't get down to 87%, but if I drop that percentage, then that is something. So you can go to 98 to 94. That's a significant drop. It's a change in your baseline oxygen saturation. Because you're talking about, I went down to 87, but if I started out at 88, you'd be like, well, you really didn't change any. You just have low oxygen in general because you have lung disease.
Right,
okay?
And we do see that sometimes. The other thing is there's a lot of data on hypoxic burden. And so how much of the study was your oxygen less than 88%? And I think most data shows, you know, over 60 to 65 minutes is a red flag. And so that can predict a lot of also some poor indicators for health conditions. So we don't always just look at the apnea index, how many times an hour are you not breathing right, but we also look at the hypoxic burden, how low is your oxygen level and for how long.
So again, hypoxia is just a medical term for low oxygen. So what else you got here?
Okay, so we did the belts. We also have EEG leads, or EKG leads. Sorry, I don't see these right here. These are these sticker pads that most people are pretty well versed in. We just do lead 2. So as you know, lead 2 is the best one to look at rhythm strips, rhythms. The biggest rhythm that we look for is really AFib. Atrial fibrillation, because we know that 50 to 65% of patients with AFib have untreated sleep apnea. So that's really the big arrhythmia that I'm looking for. Do we see a lot of PVCs, couplets? Yeah, I see that a lot. Occasionally we'll see something dangerous, like a little run of VTAC. So that's definitely something that we keep
So you see that, that's going to be like...
And pauses. We see cardiac pauses too.
So again, we think about atrial fibrillation. That is, everyone hears about that on TV. That's the person that has an increased risk of stroke. So you're talking about sleep apnea. For the break, she said, "Oh yeah, mental cognition, but also stroke, but AFib patients." And if it's happening at night, that patient probably is not even aware that that's happening.
Right. Yep. So we look for that. And then lastly is leg leads. I forgot the chin lead. Chin's kind of interesting. So, why would we want a chin lead? We also have a snore mic, but a chin lead can tell us about REM sleep because we have skeletal muscle paralysis during REM sleep. So our muscles are paralyzed. You see decrease in chin muscle tone. And so we monitor chin tone for REM sleep, 1, and number 2 for bruxism or teeth grinding. So we know that teeth grinding can be a sign of sleep apnea. It's the body's way of moving the lower jaw forward to open up the posterior airway. So bruxism can be a sign of obstructive sleep apnea.
So let me ask you this, since you brought that up, because I have that. I actually have had dental. We talked about my dentist who I grind my teeth at night, and I've cracked 2 of my molars. So I'm wearing, let's say, an appliance to prevent that. Back to the CPAP mask, which I'm looking that I may need. Can you wear that and use
Absolutely. We do have people that do both. Mm-hmm. Yep, you can wear a lot of times people don't need the guard anymore because they stop bruxing. Once we fix the airway, the bruxism goes away. But there's still a subset of patients that have other causes for bruxism, and yes, you can wear a dental guard as well as the machine.
Gotcha.
As well as mask. Last lead is the leg lead.
Legs.
I know we're on a time crunch. So the legs, you put 2 anterior tibial leads, and that monitors periodic leg movements of sleep. So very specific markings for those. So we have to see an elevation and muscle tone in the legs that occur within so many distances apart, and at least 4 in a row. And what's that an indicator of? Restless leg syndrome. And so 80% of patients with restless leg syndrome have periodic limb movements of sleep. And so we can take a look at that and have an idea of what's going on there.
And I see that even doing scopes. I'll be doing a colonoscopy, and literally I'm getting kicked and thrashed. And you go out to the family members like, "Do you get kicked tonight?" Like, "Oh yeah." So as I'm doing the procedure, I'm getting, and it's just these periodic, just like you say, it's just involuntary, just jerks.
Which can be associated with high blood pressure.
So a lot of times these people do have that.
If you're on 3 blood pressure medications or more, you should be evaluated for restless legs periodic limb movement disorder.
So again, we talk about how sleep apnea, we talk about all these different issues. So, we're getting ready to run out of time. So what we're going to do is we are going to hook me up here, and of course we're not going to have this show involved watching me sleep all night long. But Dr. Heather Clawges, again, you have multiple clinics. If someone who was watching the broadcast, who has any signs and symptoms and say, "I think I may have sleep apnea," they can contact you. And referral through primary care. And again, your clinics are where?
Beckley, Lewisburg, Oak Hill, and a new one coming into Summersville by September 1st. Yep.
So again, sleep apnea, Dr. Heather Clawges. We've been talking about how it really can affect your activities of daily living, and there's definitely treatment strategies out there. The dental appliance, CPAP mask,
GLP-1s. Do you have a talk on that? You need to.
So I think that's something we're going to talk about. GLP-1 agonists. Stay tuned. That's going to be another episode.
GLP-1. Is that bound for OSA?
That has been FDA approved, and that is a way to get some of these weight loss medications, because if you have a diagnosis of sleep apnea, we know that these drugs are helpful in that. So Anyway, Dr. Clawges, again, appreciate you so much. I'm Dr. Paul Conley. You've been watching Doc Talk. Until next time, I want you to have a good night.
Miss an episode of Doc Talk? You can watch Doc Talk with Dr. Paul Conley anytime on WZTS-TV's YouTube page or on Facebook. Catch the latest episode or explore our full library of past shows. Already watching online? Check us out on WZTS-TV, weekdays at 7 p.m. However you watch, thanks for tuning in.